So shall we start?
Yes, sir. Just 1 second.
Yes, sir, you can start your live now.
Yes, sir. You can go ahead.
Yeah, thank you. Thank you very much. We'll start with today's webinar. It is already 6 p.m. Indian Standard Time. And we'll start with the webinar. A very, very important topic today, lumbar instability. And we have got some very good experts to give us the knowledge and highlight not only standard knowledge, teaching knowledge, but tell us more about the problems, issues, complexities of the subject. We have here Dr. Mehmet Zileli from Turkey. He's from Izmir. I think he's so popular all over the world that everyone knows Dr. Mehmet Zileli. I feel very proud to tell you that he's a friend of India. He's a friend of Mumbai. He's a friend of Dr. Ramani. And he comes here to Lilavati Hospital, which you see in the background, or to Mumbai anytime to just pass an order that Mehmet, on this date you have to be here. So far, he has never ever refused. He has been here. We are very, very grateful to him. He has helped with not only lectures, surgeries, most important cadaveric workshop. He is an expert at cadaveric demonstration, and we have learnt a lot from him. Dr. Hafiz Bajamal from Indonesia, Surabaya. He is also the chief of neurosurgery at Airlangga University in Surabaya. And he trains many, many students. I'm very happy. He is also a friend of India, friend of us. And he knows everyone, who are all the speakers here, very personally. We have met so many times in India, or in Indonesia, or Surabaya, wherever it is. And I'm very pleased that he has been able to come here today and be here with us. Dr. JKBC Parthiban from South India, Tamil Nadu, is another senior surgeon who has got a lot of experience, and his lecture will be very much worthwhile for the particular topic that we have chosen for this webinar. Dr. Shraddha Maheshwari is in Mumbai, and she is working very hard, gaining expertise. And whatever she is talking today to us, it will be very, very informative, very useful. And she has a knack how to present, how to get to the hearts of the audience. I am very pleased to tell you that already we have a very huge audience listening to our webinar. They are from all over the world. And I welcome all the listeners to this webinar. I sincerely hope you will enjoy it. And lastly, but not the least, your friend who has been with me on this webinar all this time, Dr. Sumit Pawar, is a consultant, neurosurgeon in many hospitals in Mumbai now. He is specializing himself in endoscopic surgery also, pediatric surgery, and so on, So with that introduction, now we'll come to the crux of the symposium, and I will request Dr. Shraddha. Before I request Shraddha, I will hand over the mic to Dr. Sumit Pawar to offer a few comments and then proceed with deliberations of the.
Thank you so much, sir. So today the program that we have designed, Dr. Ramani has designed, is very, very stepwise. First, we're going to discuss the genesis of instability, then go with the no fusion principle, go through the methodology of fixation by Dr. Zileli, and then finally our Indian experience of stabilization in lumbar instability. So to begin with, I request Dr. Shraddha to take us through the genesis of instability in lumbar spine, why it happens, the pathophysiology, the problem statement, and please, ma'am, mic is all yours.
Okay, thank you very much, Sumit and sir, for including me in this program today. I'll be talking on genesis of instability in lumbar spine. Before we go on to instability, what is important for us is to know that what is spinal stability. So the most widely accepted general definition of spinal stability is the one which was given by White and Punjabi. They define stability as the ability of spine under physiological loads to resist dysfunction of the vertebral structure so that neither damage nor irritate neural elements, while also defer development of incapacitating deformity or pain due to structural changes. Spinal stability is accomplished by interaction of three things here. That is what they have suggested. They said that spinal stability is accomplished through three subsystems: the vertebral body, which provides an osseous structural frame; the intervertebral disc, apophyseal joints, ligaments that provide the dynamic support; and coordination of the muscle responses through neural control, which act as stabilizers. The spine may be rendered unstable when sufficient anatomical disruption of any one of or combination of these three elements occur. The next thing what one must know when we talk about instability is the anatomy of lumbar spine. So a typical lumbar spine looks like this. It consists of 5 lumbar vertebrae, we all know, attached to the sacrum below. A typical lumbar vertebra consists of anterior and posterior elements. The posterior elements, as we all know, consist of the spinous process, laminae, superior inferior facets, the transverse process. It is connected anteriorly to the vertebral body through the 2 stout pedicles. The pedicles of the lumbar region are stout and due to the weight-bearing capacity of this region. These vertebrae are stacked over each other to form the spinal canal through which the neural elements pass. The essential part of the segment that one must know is the motion segment, which consists of 2 adjacent vertebral bodies, the intervening vertebral disc, neural foramina, and posteriorly the facet joints. Now, these facet joints in lumbar region are important because these are important in the development of instability. They are oriented sagittally and therefore they restrict the motion of spine, allowing only anteroposterior or flexion extension motion. The rotational movement in this region is restricted because of this orientation of the spine. And also instability in lumbar spine is mostly in the form of spondylolisthesis, that is anterior displacement of the vertebral body because of disorientation of the facet joints. So what is spinal instability? Instability is the inability to limit excessive or abnormal spine displacement. In general, it can be acute or chronic. Acute, as the name suggests, will be sudden in onset caused by trauma, infections, neoplasia, and chronic will be a sequelae to an acute process or may be caused by degeneration. Spondylolisthesis, as we spoke earlier, is the commonest form of instability that we see in the lumbar spine. It is the anterior subluxation of one vertebral body on another and has been classified by Wilson Newman into 5 categories: congenital, isthmic, degenerative, traumatic, and pathological. We will be going one by one talking about the pathophysiology of each and some information about each. So the first is congenital spondylolisthesis. Now, as the name suggests, it is due to developmental defects. Hence, it is also called as dysplastic spondylolisthesis. It is characterized by dysplasia of the facet joints, such as hypoplasia or malorientation, or sacral deficiency, which results in subluxation. The pars interarticularis in these instabilities are intact, and the most commonly seen site is L5-S1 level. As we go further, these spondylolistheses have been categorized into 3 subvarieties. Type A is associated with spina bifida, wherein the orientation of the facet is horizontal, unlike the normal facets which are sagittal in orientation. And they have a high propensity to progress into higher grades due to the orientation of the facets. Type B has minor spinal defects, and the degree of listhesis is not very severe. Type C is associated with congenital anomalies of the vertebral body, failure of vertebral body formation, angular deformation, and deformities of the sacrum are seen in this type of congenital spondylolisthesis. The next up is isthmic spondylolisthesis. It is a result from defect in the part. Seen in the picture, pars is the result of it results in isthmic spondylolisthesis. It is also referred to as commonly spondylolysis or spondylolytic listhesis. The pars interarticularis plays a strategic role in the configuration of spine, in that it supports the anterior and the posterior column through connection of the pedicle with the lamina and the facet joints. Isthmic spondylolisthesis results from lytic lesions of the pars interarticularis or from an elongated pars interarticularis which has undergone repeated fractures and healing. Again, isthmic spondylolisthesis is also classified into 3 types. Type A is the stress fracture of pars. Type B is elongation rather than actual break in the pars, and it is most commonly seen in adolescent age group. And type C is the most uncommon type, wherein there are acute fractures of the pars interarticularis, which is extremely rare to see. The next up is degenerative instability. Now, Junghans described this type of listhesis as pseudo-spondylolisthesis, as it was not associated with pars defect. Degenerative spondylolisthesis is by far the most common instability that we see in our practice. It is secondary to long-standing intersegmental instability and rarely progresses beyond 50 degrees of anterior vertebral body subluxation. The most commonly affected level is L4-5 due to the more sagittal orientation of the facets in this region. Now, what is the genesis of degenerative instability? As we all know, degeneration is a normal process that starts in any human body as we age. So when we have the normal disc, it consists of nucleus pulposus, which is well hydrated and maintains and restricts motion of the spine. As we process into degeneration and the nucleus pulposus loses its hydration, mechanical strain starts to develop over the spine. This mechanical strain deforms the movement of the spine and leads to further degeneration in the form of osteophyte formation, facetal hypertrophy. The disc further gets dehydrated and degenerated. This leads to instability. As the load of weight bearing is now shifted to the facet joints, which are not designed to deal with entire load system. So this is the point where the instability sets in and degenerative instability is seen. Ultimately, it leads to settled space. Settled space, of course, natural fusion occurs if no treatment is taken. And with treatment also, fusion, that is what we achieve to aim in these patients. The next variety of instability is traumatic spinal instability. This results from high energy impact leading to fracture. Post-hyperflexion is responsible for most of injuries in the lumbar region. They result in pure dislocations, but when they are combined with compression or axial translation, they may produce additional neurological injuries and instabilities other than dislocation. So Denis's proposed 3-column theory for traumatic instability. He divided the spine into 3 columns. The anterior column consists of the anterior longitudinal ligament and the anterior half of vertebral body. The middle column consists of the posterior half of the vertebral body and the posterior longitudinal ligament. And the further posterior elements, that is the pedicles, facet joints, intraspinous ligaments, comprise the posterior column. Now, Denis's 3-column theory is used for traumatic instability. They propose that damage to any 2 or more of these columns suggests that the spine is unstable. However, this theory is based on radiological and not biomechanical studies, but is very useful in day-to-day practice to recognize traumatic instabilities. Also, in traumatic instabilities come iatrogenic spinal instabilities. From a surgical perspective, decompression of the central canal, lateral recesses, and neural foramen through removal of lamina, medial facet, ligamentum flavum often addresses the symptoms related to neural compression from degenerative changes within the spine, but can also decrease the stability of the spine, leading to further dysfunction. Although resection of the medial aspect of lumbar facet typically does not result in acute instability, axial loading will continue to be transferred through this region, thus accelerating future degeneration of the intervertebral disc. As such, care should be taken while performing decompression that more than half of the facet joints and the pars interarticularis are preserved. If there is a concern for instability, stabilize and fuse the affected segment. Next is pathological instability. These can be caused by systemic causes as a result of generalized bone or connective tissue disorders. The most commonly seen variety is osteoporosis, and the other are focal causes which could result from focal processes like infections or neoplasia. Now, manifestation of each of these pathological diseases is different, and they have a different natural history of genesis and natural history in the disease itself. So it's very difficult for, to pick up each pathology and describe what is the genesis over here. However, because each spinal pathology is different, in 2010, the Spine Oncology Study Group published a novel classification system which considers 6 components to score the instability in these patients, and it is called as the Spinal Instability Neoplastic Score. This score takes into consideration the following 6 components: location of the pathology, whether it is associated with pain, whether the bony lesion is lytic, mixed, or blastic, radiographic spinal alignment, percentage of vertebral body collapse, and posterolateral involvement of the spinal elements. The scores range from 0 to 18. A score of 6 or below implies a stable segment, and there is no need for fixing such patients. When you have a score of 13 and above, it implies instability and may need surgical intervention. The score of 7 to 12 are gray zones and indicate impending instability. And hence, it is utmost important that these stages are properly examined and evaluated to take a decision regarding the further treatment. To conclude, recognition of the presence or absence of spinal stability is critical for clinical decision making, not just for guiding the operative intervention, but also for informing subacute therapeutic strategies. Despite of voluminous literature, evaluation algorithms addressing this topic, the assessment and classification of spinal instability remains a significant challenge, as it demands integration of clinical history, neurological examination, and radiological findings. A basic understanding of genesis of spinal instability can help evaluate how altered spinal biomechanics and biokinematics will ultimately affect the individual patient. Also helps us to decide what kind of treatment we want to offer to these patients. Thank you very much for listening.
Oh, thank you. Thank you very much for your Dr. Shraddha, for that very lucid presentation. You have given us all the causes of instability. And we'll be taking this further. Dr. Sumit will be taking this webinar further on stabilizing procedures. But at this point of time, I would like to ask one question, Dr. Sumit. Can you highlight on this point? Dr. Shraddha said, so many types of instability, traumatic, neoplastic, of course, congenital, and isthmic, so on, and degenerative. It means that all that share defined criteria for instability. So does it mean that all have to be stabilized? Is that the answer final? What is your opinion?
No, sir. Now there are very lot of guidelines that we have for stabilization of when to stabilize and all. Like Dr. Shraddha has just now classified. If you have an acute reason for the instability, like it is trauma, then there's no question you have to go inside and you have to fuse. Either it can be external or internal. External in the form of braces. If there is a failure, then you can go ahead with internal stabilization. If there is an impending instability that you're expecting, suppose you have a far lateral disc herniation of some reason, some neoplastic etiology that in that you expect that there is going to be more than 2 columns are going to be unstable at the end of the surgery. In that case, it is better that you do the fusion in the beforehand rather than wait for the instability to develop later on. And third would be, of course, when you have a degenerative listhesis and you have a failed conservative treatment, you have given adequate amount of physical therapy, medications, bracing, and everything has been done, but still there is failure and patient is not able to be functional and he still has debilitating back pain, that would then be an indication for fusion. I'm very sure Dr. Bajamal and Dr. Zileli would be spending light on this much more.
Yeah, but you have highlighted one very important point that you see the instability. On the investigation, patient is complaining of back pain. You will not jump straight away and tell him that tomorrow we'll operate and cure is like that. You'll first try all these procedures and then go ahead, is it? I think it's a very important point that you have made it. Thank you very much. And please proceed with the remaining part of the webinar. Please.
Yes, sir. And now I would request Dr. Hafid Bajamal. This talk today is about stabilization of lumbar instability, but it is equally important to know when not to fuse. So I would request Dr. Bajamal to please speak on this topic for today, no fusion principle in lumbar canal stenosis.
Yes, thank you very much. Thank you, Professor Ramani, my great teacher, Professor Zileli, and Professor Patiban, Dr. Samit, Dr. Sarda. Thank you very much. Very nice to meet you. We are concerned of our victims occur in the COVID-19, and may the doctors in the should be make a precaution. Hopefully, everything will be passed quickly. Now I will explain about lumbar canal stenosis and no fusion principle in surgery.
So can you please start sharing your screen?
Hello?
Can you please start sharing your screen?
It's already. Sorry, I already shared my screen.
Share screen.
No, sir.
Just a minute.
Bajamal,
Okay.
press the green button below.
It's already.
Press the green button below to share the screen.
Yes.
Yeah.
Okay.
Yeah. Yeah, now it is okay. Yeah.
Yes. Okay. Now I present about the no fusion principle in surgery of lumbar canal stenosis. Okay. The point to be discussed is introduction about canal stenosis and the anatomy-pathological, most already told by Dr. Sarda, and about the surgery and the fusion and stabilization surgery indication and the outcome of surgery and the conclusion. Now about the introduction, Van Gelderen and Verbies is the famous neurosurgeon from Netherlands, is already presented in the literature in 1948 and 1955. Verbies is from Rotterdam. I'm happy that I met him during I was in Holland, and this is the famous of his literature. And the most cases of lumbar spine is lumbar spinal stenosis. It is a progressive degenerative disorder of the spine and may be localized or segmental, but sometimes may involve multi-level. It frequently causing morbidity in middle age, especially, and also most in the elderly. The diagnosis is clinical and then supported by imaging. It remains a common societal problem. Now let's see the anatomical pathology, most of already discussed by Dr. Sarda. This is beautiful image of the MRI myelography. You can see excellent picture of the stenosis, 3-level stenosis. And then from this, you can see the normal foraminal canal. And then you can see the stenosis of the foraminal canal in the level of stenosis. So there is also in the axial view, you can see beautiful image of the canal stenosis. You can see the hypertrophy of the facet, hypertrophy of the ligament, and recessus stenosis. You can see excellent view. And you can imagine how the problem is now, that the nerve in this canal will be stenotic. Let's see the degenerative changes already told by Dr. Sarda. It always nearly most of the cause is this disease, started from this disease. And the degenerative process will continue after this is extruded or disc rupture or empty disc or degenerative disc and the narrow of the disc space, and then it begin progress with the platform hypertrophy and hypertrophy of the facet. You can see also hypertrophy of the facet bilateral in advanced cases, and also it will continue with the foraminal stenosis. It will change later in alignment and also the sagittal balance. And later in a chronic phase, you can see the complex pathology of the lumbar canal stenosis. Now, if I can make in a summary, the degenerative disc can be different kind of degenerative disc. The small, larger. From this extruded disc, it will going to hypertrophy of the facet. You can see the hypertrophy of the flavum and the facet hypertrophy. And also directly from extrusion of this can directly without hypertrophy of the facet can make a problem of stenotic canal. But from another kind of extrusion of this, also they can happen on spondylolisthesis from mild to moderate to severe spondylolisthesis. And later on, this also can happen facet flavum as compensation, and then stenotic of the canal, and then later make a lumbar spine malalignment. And this is also can happen by the stenotic canal. So this is complicated problem. This is program of degenerative will continue slowly. And the neurologists later slowly will also damage. Now let's see another image. This is 3-level, this problem. And then this is multi-level with beginning of spondylolisthesis. You can see here. Yeah. So we need to evaluate the symptom. We need to evaluate the neurological condition. We need to evaluate the X-ray, flexi extension, dynamic X-ray, and then an MRI, axial and sagittal slices to see exactly what is all the pathology problem inside. And then we have to choose which one we have to choose the decompress and how we do the surgery. Now, so in summary, the lumbar canal stenosis is the pathology summary is that there is sometimes only hypertrophy of the facet and ligament flaccum, sometimes combined with canal with disc prolapse and with abnormal alignment and multiple and sometimes with complex pathology. So that is the huge problem of complex lumbar canal stenosis. Let's talk about the surgery. The indication for surgery is symptom of neurogenic claudication or radiculopathy with radiating pain. Usually the patient cannot walk more than 100 meters or impair the quality of life. And there is development of progressive neurologic deficit with the motoric weakness and numbness. And MRI evidence of lumbar MRI, you can see the stenosis of the central canal and foraminal recessus. And if you fail to do a conservative treatment for 3 months, then you can move to the surgery. Now, what are the surgery goals? First is to decompress the nerve, to alleviate the symptom, to restore the function. So this is just decompression is enough. We don't need anything, just decompression. But if there is a stability, we need to do to maintain and correction of the stability and to restore the spinal balance in complex problem of lumbar stenosis, then we have to keep in mind this is a more difficult problem. And sometimes it needs fusion. That's not always, sometimes. Now, what kind of surgical approach we can do for lumbar canal stenosis? Usually there is an open surgery, open laminectomy decompression, open laminotomy decompression, decompression with fusion combination, or there are minimal invasive microsurgery, or endoscopic surgery, or percutaneous stabilization. Now, let's see the micro bilateral hemilaminotomy for partial facetectomy. Let's see the video. Okay, you can see this with high-speed drill, with small drill, we can do a partial facetectomy like this until recessus is open, and then we move to another parts. You can see. So the beautiful decompress of the two bilateral of the facet, lateral recess. You can see the schematic picture, how the laminotomy was done to do the decompression of the canal, and then this is the imaging result. You can see the CT scan, the canals, foraminal, and then recessus is widely open. And another technique is through unilateral laminotomy for bilateral canal decompression. You just open the one lamina, one side, and from this side unroofing the other lamina, and decompress the recessus both sides. So you can see we can decompress the contralateral recessor from contralateral side. Now this is the result after the surgery. You can see the beautiful image decompression of the recessus both sides. Now another technique is Chimney Sublaminar decompression, was proposed by Professor Lin from Taiwan. This is an through splitting of the spinous process from this side. You can see this is splitting, and then decompress the canal from the from above. And what about the endoscopic and microscopic? There is a literature result of evaluation, microscopic and endoscopic decompression, less invasive surgery from Professor Fujimoto from Japan in 2015. And they said that the result conclusion is that endoscopic procedure is less invasive and safer than MDL procedure. This is only for 20 patients, and follow-up time 2 years. So, but we have to think everything to do surgery. Economic aspect is the important also aspect. With the escalating of healthcare costs today, the cost of healthcare, always consider the economic aspect and the impact of treatment modalities. What is if we face condition like, aside from geographical issues, cost capability is also a consideration. And there are still many countries that have hospitals with neurosurgeon, but they don't have microsurgery or endoscopic surgery. What about condition like this? So actually, Do not blame the technique. The skillful hands of an experienced surgeon and a good preoperative planning can give very good result even with conventional technique. Now, let's see. Open surgery technique is a standard technique and still very important and reliable. So the most important is an appropriate indication, appropriate patient selection, and thoroughness, all aspect, the anatomy, the C-arm, the gentle tissue handling, and the maximal protect facet and ligament. Let's see the fusion and stabilization problem. Now, about the fusion, from the literature, we can find that lumbar fusion in the United States increased 220% in the year 90 to 2001. And spine surgeons have a higher number of lawsuits the doctor from other specialists. If we compare with another orthopedic surgeon and another, that spine surgeon have a lawsuit problem because there is a high risk given to the potential dissatisfaction and of expectation after surgery because of chronic pain, numbness still persists after the operation, and also the paralysis. So the review article of fusion and non-fusion for the lumbar canal stenosis, degenerative spondylolisthesis without instability. There is a spondylolisthesis, but without instability. The meta-analysis is that from 1,500 cases, the conclusion does not add benefit for pain or disability reduction. There's no use fusion for patient with spondylolisthesis without instability. And also from SEN in 2018, also no significant difference between decompression alone and fusion group. And also there is one research from meta-analysis, Dr. Chang in 2017, make a conclusion that additional fusion in the management of lumbar canal stenosis yielded no clinical improvement over decompression alone in 2 years follow-up. Decompression and fusion use pedicle, PLIF or TLIF in spondylolisthesis with evidence, only with evidence of instability and kyphosis. If there is an absence of deformity nor instability, then a fusion is not recommended. So, what about the case like this? If we do decompress bilateral facet hypertrophy and we do surgery, if you're just doing one unilateral facet widening recesses, you don't have to worry about instability. But if you do bilateral facetectomy, especially like this, and you have to keep in mind there is a risk potential for instability. You have to make a decision during surgery whether you have to do fusion or not. Depend on the condition during surgery. And what about this? This is extrusion of this with ligamentum flavum hypertrophy with this condition. Do you need fusion? This is only one level disc with severe canal and foraminal stenosis and no hyperlordotic, not kyphotic. Then in the case like this, you don't need to do fusion, just discectomy, micro decompression for the canal and the recessus, no fusion. Okay, if there is a facet joint edema, facet joint is likely biomechanic predisposition for instability according to Herkowitz and Weinstein. And synovial kiss, it reflects disruption of the facet joint and subdegree of the instability. So you have to do an examination before the surgery by X-ray flexi extension, and also during the surgery you have to make a decision whether to put a fusion or not. if we have a case like this with that large disc prolapse with potential for instability like this, and this is the canal stenosis, severe with facet hypertrophy, then a risk for progression of instability through manipulation and destruction of the spinal element during compression, that fusion should accompany the decompression. So in this case, we need fusion. Now, what about this? This is a change in spinal balance scoliosis, potential causing instability, and facet hypertrophy, and antero and lateral listhesis. In a case like this, you need fusion. What about this? This is a 3-level stenosis, 1, 2, 3. And then you can see this is condition, kyphotic deformity, and listhesis of L5-1. And then high pelvic incidence. Even if there is no clear sign of instability, then in this case, you need to do fusion because there is a kyphotic deformity and high pelvic incidence. Now, let's see the outcome. For the degenerative process, need longer follow-up, more than 5 years. Why? Because the initial of all surgical decompression may decline over time due to the fibrosis, restenosis, instability, disturbance of alignment, adjacent degeneration, implant failure. So longer follow-up is very important to evaluate the clinical recovery, to evaluate the risk of post-operative instability and the need for resurgery and revision surgery. Let's see, this is the longer evaluation was done by Professor Porcher from Switzerland, from 77 patients, follow-up time 6.5 years, only open decompressive laminectomy with undercutting the facet joint, and the result, according to him, there is a high incidence of excellent or good long-term result with evaluation 6.5 years. So it means that it is really does not matter what technique you use to decompress the nerve root. If you fail to fully decompress the nerve root or introduce complication during surgery, you have failed to serve the patient. That's what McNabb, the famous spinal surgeon. Let's make a conclusion. 1, which option is the right one and for which case choose the best approach? And to see it is emergency or elective depend on clinical condition of the patient. How about your facility? Do you have microsurgery? Do you have endoscopy, or you just can do open laminectomy? What is the patient expectation is important. You have to discuss before. Honestly, now you have to know when to refer the patient to the expert one if you think that you cannot do the best one for the patient. The conclusion 2, consider the balance between adequate decompression, preservation of stability, and preservation of function. If we make an error on either side of this third component, it will add a complication to the patient. And the important conclusion is no fusion for lumbar canal stenosis without a complication, without another pathological problem. There's maybe an indication for fusion, especially with spondylolisthesis, with proven instability radiologically and clinically, and also high-risk instability associated with changes in alignment or sagittal balance, pre-op facet deformity and facet disruption during surgery. Then you need to think about fusion. The conclusion 5, we cannot stop the degenerative process. It will continue. So we have to explain to the patient before the surgery how to get a maximal prevention of reconstruction. Surgeon responsibility to continue supervision, educate the patient in order to keep the healthy spine through rehabilitation, strengthening the muscle and the bone, because the process of degeneration will continue. Thank you very much.
Thank you. Thank you, Dr. Bajamal. You have given a wonderful presentation. Most importantly, in this present era, where doctors do not look at the patients, look at the X-rays and decide what treatment should be given, you highlighted very, very important messages to everyone who is listening to this webinar. I was particularly very happy that you brought out a social point that you must respect the economic aspect of the patient and see if we can afford, because I agree, everybody today in the world agrees that healthcare has become very, very expensive, and it is going beyond the limits of the patient to spend that much money. This dictum, I was very, very happy, is coming from no other than Michael Felling from a very prosperous nation, Canada. And therefore, it has all the more reason for everyone who is interested in spinal surgery to take a very, very serious note of this and concentrate more on rehabilitation to keep the spine very healthy. And I'm also very happy that you brought out the point of maintaining the sagittal balance in the spine. Over to Dr. Sumit Pawar, please.
Thank you so much, sir, for a nice summary of Dr. Bajamal's talk. And Dr. Bajamal has so beautifully told us the risk of overuse of implants. And that's something Dr. Ramani has been telling us all the time in so many of his lectures as well. I now request Dr. Zileli, sir, to speak about his methodology of fixation of the lumbar spine in instability. Over to you, Dr. Zileli.
Thank you. Thank you a lot. Especially great thanks to Professor Ramani for giving the opportunity to be a part of this webinar. I really enjoy the previous talks, and my talk will contain the methodology of fixation. In fact, it has been remarked how to select patients for surgery. Beforehand, we must always try conservative therapies and physical therapy. We can add injections to that. They are also conservative therapies. And we must consider comorbidities, age, psychosocial status, patient expectations, and if the patient has also some sort of back pain and some deformity, surgery for fusion may be indicated. But I will not give much detail about the surgical indications. So there are mainly two techniques for lumbar instability. One is the fixation and fusion, or make a fusion. The other one is dynamic fixation. But I will not discuss the dynamic fixation because it must have another 15-20 minutes. I will make two general outlines for techniques. One is the non-instrumented fusion, which has been a historical type of fusion by many of us, because I know many of the spine surgeons currently are making instrumented fusions. But it was at the beginning of the history of fusion, the posterolateral fusion have been used most often. Instrumented fusion can be divided in two sessions, one posterolateral fusion and the interbody fusion. Posterolateral fusion is placing the autografts on the sides of facet joints or isthmus and on the transverse processes. It is also necessary to make some decortication of the bone at those levels. The Wiltse approach is by making two separate incisions, not on the midline, but on the lateral part of the spine, so that you can open the area via the muscular corridor, and then you can place your grafts on that side. What are the advantages and disadvantages of those? Non-instrumented posterolateral fusion is easy to apply. There is no implants are necessary and less bleeding. But disadvantages need post-op immobilization and bracing. You must keep the patient in the bed. In the beginning of my residency period, we were keeping the patient in more than 1 month in the bed. So then letting the patient with a brace, some mobility. Fusion rate is approximately 60 to 70%. It's not very low, actually. What about instrumented posterolateral fusion? It is also easy to apply, but it may be bloody because you have to place screws. Cannot increase disc height. Fusion rate is about 75 to 80%. What about instrumented interbody fusion? You can achieve sagittal balance, open foraminal narrowing, so then these are bigger advantages of interbody fusion. But it may be technically demanding. It may be a bloody surgery, but fusion rates is about 90–95%. Very good advantage, actually. I have placed it on the disadvantage part, but it's an advantage. Why do we add fixation implants during fusion surgery? Because we want a bigger fusion rate, enhances fusion rate, and it confers immediate stability. If the patient has back pain because of instability, then the patient will have immediate postoperative pain relief. And it restores the alignment. Instrumented fixation, you can achieve good alignment of the lumbar spine. If you come to interbody fusion, bone grafts placed between the disc space, fusion is achieved at the center of the motion segment, then it is facilitated if the grafts are under big loads. Loading is necessary to achieve a good fusion. Actually, because of that, posterolateral non-instrumented fusion, the non-union rate are somewhat higher. If curated, this space is very vascular, promotes a solid fusion, and a very wide area for grafts can be gained by interbody grafting. As I mentioned before, normal disc height is preserved. You can achieve an intersegmental destruction, foramens open. Disc height subsidence is prevented, and normal sagittal alignment is achieved. There are mainly 4 types of interbody fusion. One is posterolateral interbody. The other one is transforaminal lumbar interbody, anterior lumbar interbody, and XLIF or extreme lateral interbody fusion. In some period of time, we have placed bone grafts only or bone graft and cage only. Actually, if you do it for PLIF surgery, we have seen that it's risky because the cages may back out. This is a case of mine with bone graft only, a solute fusion in 1 year. You can see how good is the interbody bone healing. For PLIF surgery can be done with a very familiar approach. However, it has significant disadvantages. The retraction injury to the nerve roots may happen because you enter from here. Need bilateral opening and graft cage insertion because most surgeons recommend bilateral graft or cage insertion. Potentially destabilizing because you have to remove a part of the facets on the sides. Non-instrumented PLIF surgery has been abandoned by many. In fact, it has started by Cloward in 1943. The Cloward has developed PLIF technique. He has published it in 1953 with 85% success rate in treating disc herniations. And he has used 3 cortical grafts, like you can see here. But you can see how much distraction is necessary to place a graft from a PLIF approach. By the time we have seen treated BAK cages, it was placed like a screwdriver, mesh or harms cages. We have seen peak cages, and recently we are having the carbon-coated P cages. So by the time the cages, the substances and the materials have been changed. This is an L4-5 disc herniation spinal stenosis patient, has been operated by PLIF cage insertion, but you can see even here, the facets are largely removed, and after a while, one of the cages has been protruded backwards. So the patient became more painful and unable to walk. And we have to revise it many years before by making a short fixation with pedicle screws. This is PLIF with bone graft and pedicle screw fixation in 2 levels, and good fusion has happened after 1 year. The recent trend is applying transforaminal lumbar instability fusion. You can apply it unilaterally, always added posterior fixation. Nobody must do it without any pedicle screw fixation. Main aim is to avoid root injury caused by during the PLIF surgery. Advantages are less chance of root and dural injury, and ligament to flavum and interspinous ligaments are preserved. Probably less time consuming than PLIF surgery and less bloody than PLIF surgery. First place, pedicle screws. Destruction of the screws facilitates this space opening, and a robust cage insertion may be done. And unilateral facet resection, exploring the root, discectomy, and curettage of space, and sponges or strut graft of cage may be inserted. These are some steps, as you can see here. First, screws are placed, then one-sided rod is placed, then it was distracted, then you can work on the other side, see the traversing and exiting nerve roots, and work in between them after resection of one facet, and then you can place graft or cages, anything you want. At the end, some compression of the screws before tightening of the screws is better to achieve better fusion because overloading of the grafts or cages are better to get a solid fusion. This is one of the cases with P cage. I first place some grafts in front of the cages, then cage, then some more grafts again. This is like a sandwich style of interbody fusion surgery. I apply it this way. It may also be done by a paramedial muscle splitting approach and a tube-guided surgery. You can, from a 26 millimeter tube, you can remove one facet and then place the cage from inside. You can even use bilateral approach for that purpose. What about ALIF, anterior lumbar interbody fusion? The main advantage of this technique is no injury to posterior structures. If the patient has had previous surgeries, because of the great scar tissue, you cannot do a good PLIF or TLIF surgery. So ALIF is a better option. Besides, better correction of lordosis and other deformities may be achieved because you are placing a cage in the very anterior part of the interbody space. Disadvantages are difficulties of anterior approach, great vessel injury, and retrograde ejaculation. And you may need an access surgeon, and a vascular surgeon or general surgeon you can take with you. Retroperitoneal approach you must use. There are also some mini open approaches. Here is a technique with small incision on the side, or you can make the same incision just lateral to the midline, parallel to the rectus muscle. You must know before surgery the shape or anomalies of the great vessels. And you must be careful for hypogastric plexus and sympathetic nerves at the region. However, another disadvantage is posterior stabilization should be added in most of the cases. There are some ALIF cages with 2 screws to place into the body, so then it may be more secure, like the cervical cages. But you must be careful for complication if there are osteoporosis, previous disc space infection, spondylolisthesis, and 2-level approaches. This is one of the anterior place to secure the ALIF cage or graft inside without a posterior fixation. I will try to mention one more approach, XLIF, or better to say it is a transpsoatic approach. You can come from very lateral part. It was first introduced by Dr. Pimenta from Brazil in 2003. A large cage may be inserted, but there is a lumbosacral plexus here, and then EMG monitoring for plexus injury is necessary. Special retractors and special cages are necessary. So it's somewhat more technically demanding than TLIF surgery. Another thing is L5S1 is not possible, and L4-5 is a risky region because at that region, the risk of injury to the lumbosacral plexus, especially the L3 nerve root, is quite high. Many patients are having transient and even some permanent numbness and some motor weakness on the anterior part of the thigh. You can, however, achieve some sort of deformity correction with this technique. If you come from the convex side, you can correct some degenerative scoliosis. Since there are a trend to not to perform at L4-5 level, L5-S1 is completely difficult. So the levels have been very shortened. Many people are abandoning direct transpsoatic approach for fusion, and probably there is a new trend of OLIF surgery, oblique lateral interbody fusion surgery. I want to mention also the axial LIF. This was introduced for L5-S1 fusion by a sacral hiatus approach. You can enter the S1 body and then place a dowel implant inside the L5 and S1 levels and place some grafts here. This is so-called axial LIF, but it mostly needs additional fixations, either pedicle screws or facet screws. Standalone usage ends with very high non-union rates, and need additional postural fixation, high non-union rate, and reported major complication, ball penetration and exarchy. This technique has been left by most surgeons, and it's like a historical minimally invasive technique. Almost no surgeons are using in the world. If you look at the complications of fusion surgery, this surgery complication is about 10%. Fusion surgery complication is about 20%, quite higher. So then our indication must be limited, and they must be as short as possible. I will mention something about the MIS pedicle screw fixation. It's better if you don't want to injure the muscles, but you then need a fluoroscopic control or CT navigation, mostly by AP views, and you need specially designed screws, with key wires, so cannulated screws you need. And placing a rod may be more difficult, especially for multiple level fixations, but it is possible. This sextant system has been described by Kevin Foley, who have also introduced the tube-guided surgery. There are some advantages and disadvantages, but the biggest disadvantage is more radiation for surgeons, because you have to push the foot switch of the C-arm very often, so that you can get more X-rays to your body. I will give you some examples. This is an L4-5 fusion with PLIF using local bone chips. Very solid fusion has happened after 1 year. And this is another case, two-level pathology. We have placed P cages and bone grafts. As you can see, in front of the cages there are grafts. In the backward of the cages there are also grafts. So if you can see the bridging of the bone fusion, then you have achieved good fusion. This is another case. Okay. In conclusion, posterolateral grafting plus minus pedicle screws may still be a good option, but the fusion rate is somewhat lower. Interbody fusion provides better fusion rates. They compress the foraminal height, provides better lordosis. If you want to correct some sort of deformity, it's better that you use some interbody fusion. TLIF has more advantages than PLIF, ALIF, and XLIF. Axial LIF has been abandoned. These are my messages. because of COVID infection, we have to restart our meeting Istanbul Spine Masters to October 1 to 3. Also, we will make it with full endoscopic course. And we have also restarted our Milan meeting to March 2021. Dr. Ramani, Atul Goel, Michael Ferrings, Roger Hartle, Ortel, Max Avis, Spalski will be there. I wish you, we will be all together in future live meetings, not that webinars only. And please follow us on WFNS Spine Committee website. We have many recorded webinars there. Thank you for listening me.
Thank you. Thank you very much, Mehmet. You have taken us through the whole gamut of stabilization which is available in the world, including Louis Pimenta's X-Sleeve. You have given your conclusions also, but with so many varieties, so much coming, so much technology. Give your wisdom, one word, 2 sentences of wisdom. Where are we going? What is the right thing to do? Please, come again.
Yeah, I can tell what is my preferences. Actually, I try to be as short as possible on the fixation levels. If you add 2 more levels, 1 more level, then you can expect more non-unions or more problems. If I'm correcting anything, if I'm trying to correct any deformity, I always use interbody fusion. But posterolateral fusion is still a live option. If you don't try to correct any deformity, if the patient is somewhat very elderly patient and the Karnofsky score is not very good, you don't want to bleed too much, you can still make posterolateral fusions. These are my messages now.
Thank you, thank you, thank you. Thank you very
Thank
much.
you.
Dr. Sumit Pawar.
Thank you so much, Dr. Ramani and Dr. Zireli, for an excellent presentation. You took us through the journey of the fusion from past to present, what has been on lateral sides as well. It's everything very nice to hear, very nice to learn. When it comes to young surgeons like me from an Indian subcontinent, I also need to know what is applicable in our scenario. And I'm sure the webinar attendees who are from all over the world, I see many third world countries that are attending the webinar. And for that, I would like to welcome Dr. JKBC Parthiban, who would shine some light on how to deal with the situation in an Indian perspective. Dr. Parthiban, all yours, sir.
Thank you. Sumit. I hope you are able to see my screen. Hello?
Perfect.
You're able to see my screen?
Perfect.
Yeah, thank you. Thank you, Professor Ramani, my teacher, my guru, and my dear friends, and the so many audience who are seeing this webinar in a very, very positive way. The stabilization of lumbar instability, the Indian experience. Personally, I'm one surgeon and I cannot give the complete Indian experience, but then I can give some cream of what is being done in India. This will be wide open because it's more understandable both the developing country and also the developed countries. Now we all know about this particular posterolateral fusion was done years together. You know, it was done every other day by our senior surgeons, our teachers, our elders, and our fathers. As Professor Zileli was telling, that you put a lot of graft posterolaterally and put the patient on a brace for rest for 1 month or 1.5 months, then mobilize the patient. You do find some fusion happening there, but the fusion rate is very, very less.
Arthi, make full screen. You are on full
Okay.
screen.
It's okay.
Yeah, good.
So, so this was the routine surgery which was done when we were very young, when we were very, very young. And then suddenly we started hearing about something about this particular pedicle screws. When we started our career, Professor Arthur Steffi, and we started looking into what is happening, what is this kind of some very rigid screws are coming. And this is one of the pictures of Professor Arthur Steffi. And he has made some nice statement about the life. There are some people who are born to do something positively. There are some people who are there just to see what is happening. There are some people who always think why this is happening, how this is happening, this kind of thing. And this is true to our spinal surgery also. When we speak about Arthur Steffi, who was talking about the pedicle screws, who brought the pedicle screws to more familiar to the Indian experience, we cannot forget Professor Ramani, who introduced the interbody fusion to the country. So the mix of the Arthur Steffi pedicles and Professor Ramani's the thrust in introducing the PLIF in India was the rebirth of new generation, newfound spinal stabilization in our country. Before that, we had some heart seals, some Lukey rods were there, but that may not be much useful in the lumbar region. So we started learning from Professor Ramani. We started learning from him how to put the grafts, how to put the graft, where to put the graft, PLIF. This is the most fascinating surgery when I was young. And I started learning this surgery because it had a sense in that interbody fusion is very important because it takes a whole lot of the anterior surface and also the anterior segment of the spinal segment. So we started learning this PLIF and we started using. Those days we had one problem because the pedicle screws, Arthur Steffi pedicle screws were rigid. They were very good at L4 and L5. And when it comes to L5 and S1, with the listhesis coming from grade 1 to grade 4, 5, 4, it was more difficult. However, we were able to do that with all the best results forever. A PLIF was there, and most of the years still recently, we started understanding about TLIF. Now, why TLIF came? I was just thinking about it. A TLIF came surely because of easiness of the surgeon. The principle of interbody fusion is the same. It has not changed. The corridor through which the interbody done has changed. That's all. Number one. Number two, it has reduced quite a bit of neurological deficits that happen, particularly at L4 and L5 and L3 and L4 in PLIF surgeries with inexperienced hands. So there was a concern when you start removing the facet, then you have to put through the transforamen, you can do the interbody fusion. So TLIF started gaining popularity in our country very recently, not for a long time. Now this is the operative technique. You can see these are the microsurgical views. You can see very beautifully there is one pedicle screw placed on the upper vertebral body, and the cage is inserted through the transforaminal approach into the disc space and then pushed into the intervertebral, that is the disc space very deeply inside. So this is a classical TLIF. Now we started doing the TLIF much more and more familiar, more easier, and it is more less challenging than PLIF. In fact, when I keep thinking about it, because we've gone through this generation, We've gone through this generation from PLIF to TLIF. I realize still PLIF we can do very well in L5 and S1 region. For grade 1 and grade 2 listhesis with any kind of fusion, PLIF is very good at L5 and S1. In L4 and L5, yes, it depends on the kind of case we get. If we have a good canal, then we can always do PLIF, and TLIF is now being more done. I like to go through some of the cases you can see here. Here is a patient with L4, L5 degenerative listhesis. You can see it must be a grade 1 listhesis, and a TLIF is done with a titanium cage and autograft. So as Professor Jalali was telling you, mix up the graft along with the titanium, the graft, the titanium push, and then push some more autografts. And then also you use your pedicle screws fixation. But nowadays pedicle screws are very good because they are polyaxial. They are easy to be inserted, and there are so many developments in pedicle screws. This is another case. Probably this patient is going from L1, grade 1 to grade 2 listhesis. You can see the disc which is coming at L4, L5 disc level. And this is again done with a TLIF with a titanium cage and autograft. The markers you can see very well. The markers shows that there is no facet joint. So the facet joint is completely removed. The door is open. The door is open and you enter in and put the interbody graft as you like. The interbody grafts coming in many designs. So many designs it is coming. Now another patient here. Here is the patient. Very interesting is that how to do this kind of cases in osteoporotic bones. That's the most challenging in osteoporotic bones. In osteoporotic listhesis, TLIF is still possible, but I always prefer to put a long screws. Try to as long as possible, and sometimes even to bicortical purchase. And those days, I remember when we don't put the screws exactly into the pedicle, we call it a suboptimal placement of pedicle screws. But today, the same suboptimal, when it catches at the cortical purchase, is called as the cortical purchase of the screws. So there has been, the terminology has changed, but then the effect of these long screws, particularly in osteoporotic listhesis, is very valuable. We can also see here this completely, it is filled with autografts. Whenever there is an osteoporosis, I do not put any cage. I don't like to put the titanium cages or P cage. I just believe in a pure autograft because the subsidence is reduced if we can use only the autograft. Autograft, we all know that it is one of the best grafts available in the world at present. This is another patient you can see here, L4, L5 listhesis, and there is a minimal listhesis. Actually, in fact, more than the forward, it is actually trying to list this by an extension here, and this is being jacked up. You can see the direction of the screws. They are very important here. The direction of the screws are directed more divergent because you can get a distraction, put the screws and then compress it so that the grafts can fuse very nicely. Between May and August, you can find the fusion started taking over. So the putting the pedicle screws is also very important. In each type of cases, you have to choose how to put the pedicle screws. The pedicle screws are not just putting into the pedicle screws. So some patients need a divergent screws. Some screws need to be in the cortical. It depends. So each patient has to be selected nicely. Now in this case, I have selected a P cage. This is again an osteoporotic. In this case, I prefer an osteoporotic because at that time I was thinking, should I use a metallic cage or a P cage? But when the metallic cages were rejected, then we start using the P cage, which has an embedded tricalcium phosphate. So you use such kind of substitutes also along with this. Now, why I'm able to tell all these things is because in India, we are able to get most of the type of cages and the bone substitutes as well. So that is why we are able to use all these things in our practice. Now, very rarely, sometimes, this is often we keep seeing this kind of cases like post-laminectomy, discitis, and then become unstable. This is the most disgusting for the primary surgeon. It never goes to the primary surgeon. Sometimes it goes to the next surgeon. So similarly, we get, some my patient may come to you, your patient may come to me. But then when the laminectomy alone was done for a wide decompression, and the facet joints are destroyed, and along with the infection, there is, you can see here in the CT scan, you don't find anything there. There is no disc there, and it looks very corroded. And this is a potential case which you can go in for an instability. So these cases nowadays, we started doing the minimal access spinal stabilization. In minimal access stabilization, in this case, what I have done, on one side, I have done the pedicle screws percutaneously. On the other side, I have done a minimal exposure to open to the two pedicles on one side, and did the TLIF through the same approach. So what is the benefit of this particular, you can see in the picture which is down, you can find an arrow which shows the midline, primary midline incision. Now our incision are more lateral. So there is a minimal muscle injury. So the stability is again being reconfirmed by doing the TLIF and also with pedicle screw fixation. So this is a newer generation. And as Professor Jileli was telling, that you should be careful with the amount of X-rays you use, careful with the C-arm, the number of shoots you use. Now we started using the navigation system for this. So once if the navigation system is introduced, then probably the side effects of radiation will come down. Having said this, spinal stabilization is very good along with interbody fusion for grade 1 and grade 2 and grade 3 listhesis. But then sometimes what happens, it is very difficult to get into higher grade patients, particularly in dysplastic listhesis with grade 3 in adult. In some of the cases, you end up technically, some of the cases you end up technically to do in situ fixation, in situ fusions. I'll just show you a few cases, and you can see here. Here is a patient which has already, there is already severe listhesis. And in this case, I was not able to reduce it. So we did only the decompression and then in situ fixation with posterolateral fusion. It's a short segment instrumentation. In some patients like this, you can see grade 3, it is slowly grade 2 to grade 3. Here we did a long level, that is the more than 2 level pedicle screw fixation, but with posterolateral fusion along with the decompression. This is another patient. Here it is very interesting is sometimes we try to send the screws more angulated towards the disc because anyway we know that the disc is not useful there. So try to send the screws through the disc space into that, but this is in situ fixation. And you can see that in the lateral aspect on the right side, the fusion has already formed very beautifully, posterolateral fusion, but with pedicle screw stabilization with the 2-level stabilization. Now, there are some advantages of in situ fusions. Several effective options are available. You have involved low risk neurological complications because the technique of reduction carries challenging of meeting more side complications. So that is very important. There is an acceptable fusion rate, though we cannot. Interbody fusion is very good, but in posterolateral graft is an acceptable fusion rate up to 75 to 80. But easy for all spine surgeons. If somebody is not able to reduce it, or the patient situation is such a way that you're not able to do, then you can take this as an opportunity to institute. I'd like to take to you now a nice, very most interesting aspect of what I learned in Indian experiences dealing with high-grade spondylolisthesis. I found this technique very much useful in situ fixation with transsacral orthodesis. I'll just go through a few pictures. The management of high-grade spondylolisthesis of grade 4 is controversial in surgical practice and within the literature. If you say, there are so many people will say so many different things. You can do a spondylectomy, then you reduce it, or you do just in situ fixation. It is all depending on the case-to-case basis. And finally, we have to have a very safe patient with good fusion. And there should be a cessation of progression of the disorder. Now here, we always have to see the slip angle. The more the slip angle, it is more it is following. So when we see a patient 2 years ago, the slip angle is less. Now next time when it comes, the slip angle is more. That means this patient is progressing. This patient is not. So this patient, when it is progressing, then you need an instrumentation. If it is not progressing, but there is the progression of the symptom, that means if the slip angle has not increased, but symptoms have increased, then you can just do a decompression as Professor Bajmal was telling about it. This is what it shows in this picture. We always have to think about the sagittal balance. We have to take care of the pelvic incidence here. The moment the patient has a high-grade listhesis, you can find the patient going for a severe stiff back and try to compensate with the thoracic curve and also with severe back pain. So this has to be managed. To manage this, you have to correct. But then in spondyloptosis, it is very, very difficult. So it becomes a vicious cycle in case when the pelvic incidence increases, it causes increased biomechanical loading and translation and again become spinal imbalance. So we have to stop. We have to arrest this imbalance to occur. Somewhere we have to put a fixation and we have to have some fusion technique to stop in these cases. So in high-grade listhesis, we always expect to have a pseudoarthrosis, persisting mechanical back pain, radicular symptoms. There will be continued translation, progression, and increased slip angle, which I told you already. And what is happening is the posterolateral fusion alone, if you try, you have a non-union rate of 8% to 45% in high-grade listhesis. I'm talking about high-grade listhesis of L4 and then spondyloptosis. The fusion rate is very, very long because there is a stress factor. It is like Professor Ramani used to say, compress the graft, compress the graft. You compress the graft, fusion is more. If you don't have a compression, the fusion is less because the graft is in a loose position. So you have a very, very bad fusion rate. The non-union goes from 8% to 45% when you do only posterolateral fusion. So, the rigid instrumentation and restoration of the lumbosacral competence, either through anterior grafting or restoring and spinal alignment must be the aim. So we have to think of this particular point in dealing with spondyloptosis. I'll just take you to this. So what should we do? Well, should we do only the posterolateral or we have to do something to do with the anterior column support? How to do the anterior column support? Professor Jaleli was showing something through the post-rectal approach. It is pretty scary. So you have to go from anterior, it is very difficult. So we need to devise something from posterior vertebral, but it should go to the anterior aspect of the instability. So in term that we get a circumferential fusion. We get a circumferential fusion, but we also have to put the instrument. I just go through this. There are so many options, but this option is very important. Postural reduction, circumferential fusion with transfibular interbody fusion, providing anterior column support with the decompression and instrumentation. Now, this is the technique. I'll show you this technique. This is the technique. Yeah.
Please be short.
Yeah. I'm finishing it. So this is this is very important. You can see about from the sacrum, you push, you drill it down into the L5, which is more anterior. You have to drill it, and then we can do with ACL reamer, 10 mm reamer, enter into the, from sacrum, enter into the L5, and subsequently it has to be guided by the image intensifier, and the pictures are self-explanatory. That is the place where you have to put the graft, and the fibular graft has to be taken and push it into the fibular graft. This fuses from L5 to S1, and then put the pedicle screws. This is one case. And here you can see the last myelogram era. There's a listhesis of grade 2 has become grade 4 and optosis. And this patient again was done with the same technique, transsacral fixation with pedicle screw fixer. So it gives all sides, posterolateral, anterior, and also pedicle fixation. This is the post-operative pictures. And finally, this is the post-op picture you can see here. The construct is very good. And before I put the last case here. There is another technique which is developing now here is not only transsacral, you can push the screws from the transpedicular into the L5 vertebral body, which is anteriorly placed. You can see here, this is another cases. These cases are very difficult. Spondylectomy is difficult because the complication rates are up to 30% in the best of the hands in the world. So this is what we have done, transpedicular vertebral body screws through the pedicles and then enter into the vertebral body, which is anteriorly optosed anteriorly, and then put the fusions posterolateral and combine with this. So thank you very much for your kind listen. Thank you, Professor. Thank you.
Thank you very much, Parthiv, for giving us a detailed Indian perspective. You have done a very good job, and finally, you have given us also some answers for the difficult propositions. It was a very illustrative lecture. Thank you very much. Dr. Sumit Pawar, please.
Thank you so much, sir. Thank you so much, Dr. Parthiban, for an amazing and excellent journey that you took us through for the Indian subcontinent that we can use very well. The kind of patient that come to us present very, very late, and so we have a lot of pathologists to deal at the same time. And this has been covered very, very nicely in your lecture through a pictographical, I would say, a review of all the levels of cases. We are bombarded with a lot of questions right now over here, and I request Dr. Ramani to please take over so that we can ask questions for the audience.
The topic chosen for the webinar today was very, very complex and very interesting. It's no wonder that a lot of people from all over the world are listening to this symposium, and we have received more than 170 questions. It's not possible to discuss all these questions. I will take a few questions here. The question is from Muhammad Salimi, and I will request Dr. Mohamed Zileli to answer this question. Mehmet, the question is, how do you predict lumbar instability? Are you listening, Mehmet?
Yes.
Yeah. How do you predict lumbar instability in patients undergoing lumbar laminectomy and discoidectomy? That is question. I would like to add a corollary to that question myself personally and ask you also, have you ever used ANN, artificial neural network, to predict instability in a given lumbar spine? Please, Dr. Mehmet.
No. Actually, diagnosis of degenerative lumbar instability is quite confusing. There is no good consensus on that. We must start with that. Because it's a so-called sliding type of instability. It's not like traumatic instability or tumor-related instability or deformity. It is really a sliding and ligamentous type of instability. And if there is instability, there is also additional back pain, most of the instances. Rarely, there may be no back pain, just sciatic pain or femorrhagia. So I don't think our indication must be placed only with radiological criteria, but also the clinical criteria.
Yes, very important. Yeah, quite right.
These are very important.
Yeah.
Since, I am criticizing to discuss any patient with only radiology of the patient. But there are some certain indications of radiological instability criteria, like the movement in the flexion extension films, the modic changes of the disc space, and the facet, severe facet degenerations. There are some signs of instability, radiological instability. But clinical instability criteria, for instance, the patient's inability to be erect position, having back pain with the levels palpation, and inability to forward bending and extension. These are also the clinical criteria of instability.
Yeah.
Is it the answer? I don't know, actually.
Yeah, okay. Thank you. Thank you, Mehmet. I will ask one question to Dr. Shraddha. In your lecture, you mentioned the name of Dr. Jungans, way back in 1932. Jungans also described a condition, syndrome called kissing spines. We forgot about it, but then in 1978, Kirkdale and Willis described three-zone concept of degeneration, and that opened our eyes to today we respect kissing spine is a very, very important condition which requires attention. Dr. Shraddha, what is your opinion on that?
Of adjustment spinous process due to degenerative changes is what kissing spine is. And this also is important in analyzing instability in the spine. Like Dr. Zileli said, evaluation of clinical parameters along with this is important to reach a conclusion whether we need to fuse these patients or not.
Yeah, very important. No? Yeah. Thank you, Dr. Shraddha. I will move on to Dr. Bajamal Hafid.
Yes, please.
There is a question by Dr. Shresht. How much instability will be caused? Very simple question. How much instability will be caused by unilateral facetectomy?
That is, clean during surgery after we did facetectomy. Then we have to check about the fixation of the spine. Then we decide whether we need or not to do fusion. Usually, one level facetectomy in the long term will problem to stability of the spine in the long term. But sometimes in the short term, there is no problem. But in the long term, total facetectomy, I will do fusion.
Yeah, thank you so much. Thank you. Now there is a question by Dr. Sushil Patkar to Dr. Zileli. What is your endpoint of interbody fusion? What will you call it, Mehmet? Interbody fusion or interbody bone union? Which is the endpoint? Bone union or bone fusion?
Union and fusion is the same thing, actually. We cannot differentiate them. But actually, I understand the question that if the fusion happens, do we need those implants there? Yes, we can remove them, but in fact, since it needs another surgery, we don't do it regularly. We don't remove these screws. But there are certain conditions like some burst fractures of the thoracolumbar spine. You can place short fixations and then remove them after 1 year. This is so-called a fusion period we provide the patient. And then in that period, in 1 year, patient will have no pain at all. So the main concern about having a fusion surgery is the adjacent level degeneration or adjacent level disease. If that happens, we will have problems for instance, another surgery may be necessary. To prevent adjacent level disease, we must achieve a good lordosization. Lordosis must be provided, and we must do as short as possible fixations instead of making other levels as well. This is my answer.
Yeah, but how do you define lordosis without mentioning sagittal balance?
Yeah, lordosis, if you achieve lordosis, you then have corrected the sagittal balance. Yes, this is the almost same things.
Yeah, okay, thank you, Mehman. Dr. Parthiban,
Yes, sir.
you made one statement that is correct, which I have been telling everybody. Best fusion is bone graft and compression, of course, that is later. Now, times have changed and there is a lot of bone material is available in the market, So now, what would you prefer? What will be your message? Would you use the autograft or will you use bone material?
All right. Thank you, sir. At present, what I'm doing is I mix the autograft, which I take it from the facets and the spine and lamina when I do the laminectomy, and mix with the tricalcium phosphate, TCP. Now, TCP is available. So we don't put only the TCP, tricalcium phosphate, but I mix with the auto bones, which I take it while I do the facetectomy. I don't waste that bone. So I mix those two bones like a gravel and then use it along with the P cage or a titanium cage if needed. So I mix this in the present condition.
Yeah, very good. Thank you very much. I think when I used to do PLIF in the past, as Dr. Parthiban had outlined, I used to take a lot of bones from the iliac crest, allograft. That is autograft, we call it. We don't need now, because the availability of these bone materials, to do so much big incision on the iliac crest and take so. But finally, the last word will be, you use the bone material which is available in the market, always mix it with some autograft, and that should be the message, correct?
Yes, yeah.
I will ask one more question while you are there. You mentioned in detail about the TLIF and how do you showed some pictures and the procedure of the TLIF is very easy to do and you use the pig grafts and everything you showed, Only 2 pedicle screws are enough, Now, in this scenario, would you use PLIF or not?
I will use. Yeah, this is very. I will definitely use PLIF in select cases. For example, L5S1. In L5S1, my preferred is, but we don't need to take the facet because the facet is wide far away, and we have enough space to do. We don't need to remove the facet to do the interbody fusion. So PLIF can be done very well at L5 and S1 region, and at the same time at L4, L5 also. But when we go higher and higher, it is a little bit difficult. Even at L4, L5, I always see the volume, the size of the facets. If the facets are very, very bulky and it is occupying the lateral canal, then I like to do the TLIF. So that is how I have fashioned my indications for PLIF and TLIF. I still use PLIF. I still use, sir. I do PLIF in most of my L5 at S1 level, number one. Number two, at L4 and L5, where the facets are reasonably good, they are not hypertrophic and they are not very, very bulky and short. In those cases, I do the PLIF.
I
No,
think
I accept L5S1, but 4-5 is not that much easy. I don't think 4-5 is a good level for PLIF.
4-5
L5S1 is okay.
Yeah, 4-5 is not, I agree with you entirely, Mehmet. 4-5 is not a good level for TLIF. Yeah, you are right, absolutely. Correct, that is where. So yeah, at 4-5, in comparison to L5S1, always you will find good facet joints. You may find it a bit sorry that you have to sacrifice it. And what you said is correct in that respect. So there is a role for PLIF even in the present era of TLIF. That is the message, okay? Now I will ask one last question because we have to conclude somewhere. Everything is going very interesting and all viewers are listening very intently. Nobody has left. I will ask Dr. Sumit Pawar. In fact, he is very much in for endoscopy. What is the role of endoscopy in stabilization of the spine in the present era? Would you advocate it, or would you use it ambiguously, or would you use it as an alternative method? What is your answer?
Sir, I am using right now, not endoscopy, but I'm using MIS TLIF technique using tubular retractors. And with that, using a microscope with tubular retractor, I'm getting very good success. I'm using only TLIF, not PLIF with that technique, because then I need to have some bone. With facetotomy, I get a lot of bone with that technique as well at the same time. So I would say MIS TLIF with tubes is a better option. I have just started endoscopic surgery, but very few surgeons from South and most surgeons from Korea, they are using endo TLIF. So with the transforaminal approach that they're doing endoscopic removal, they are putting a cage through that portal itself. I don't think those cages are available in India right now. And I have not tried that endoscopically.
No, you talk with the Indian, very important message. We have to respect the economic status of the patient also. You know? Keep that very much in the mind and then give your answer. Don't say because it is not available in India and therefore nothing. You must respect economy of the patient also, which is very important for us. We are not very affording nation generally, and therefore this point is very important. And in that context also, how will you place this question?
The MIS TLIF, I would say, is extremely cost effective as far as if you compare it with the PLIF. The surgical time is much less, and the cost of implant, the percutaneous and the open system is not much different. Today, because of the competitive market, the costs have dropped significantly. And today we are able to use percutaneous PLIF system, the pedicle screw system, along with the TLIF cage, is almost the cost is equal to the open system at the same time. The time of surgery is quite less. Within 2 hours, we're able to finish the surgery. Mobilization is much faster. And that's why I think this is actually more cost effective than open PLIF. I may be wrong in my approach, but that's what I think.
Thank you, Sumit. See, all good things must come to an end at the right time, you know. I think we have spent a lot of time here, and it is my obligation now to call an end for this very, very lively, very interesting webinar. I take this opportunity to thank very sincerely Dr. Shraddha, Dr. Mehammed Zileli, Dr. Hafiz Bajamal, Dr. JKBC Parthiban, Dr. Sumit Pawar, and our technical team supported by Intas Pharmaceutical. They have been very, very generous and we have been supporting our webinar technically. And most importantly, not to forget the viewers. You are most important. Your viewing makes this webinar more successful. The more the number of viewers are there, the speakers, everybody get a lot of encouragement. And I'm very happy that today more than 500 viewers are listening to our webinar. With those words, once again, I thank you all, everyone, including our technical team from the Intas Pharmaceuticals. And I declare this webinar today is closed.
Thank you, sir.
Thank you.
Thank you.
Thank you,
Thank you very
Professor
much.
Ramani.
Thank you, everybody.
Thank you, sir.
Thank you. Thank you, sir.
Thanks, everybody.
Thank you.
Bye.
Can you,
Thank you.
can you please stop the streaming?